everyone, and welcome to Chapter 13. We are going to talk about sexual disorders and gender variations. Now, I wanted to say something really important before we begin this chapter. Notice that we are not talking about sexual orientation. We will talk about it in context of how it could have. People of different sexual orientations could have these disorders, but sexual orientations, whether someone's heterosexual or homosexual, all fall within a spectrum of normal. So there it is not abnormal or poor mental health to be attracted to people of the same sex as you are. So I just want to clarify, we will not be talking about sexual orientation as a result of this discussion. And what I'm going to try to do to condense some of the material is kind of just give you the main points, because I know I did a really long PowerPoint again. I gotta cut some. Do the main kind of points for you all, and anything that I think may be a little confusing. So, let's get into it. I think our text does a really good job of, it wants to skip. I've included this great video. It's kind of a recap. It's a crash course video. It says, let's talk about sex. And it's really good information concerning the initial Masters and Johnson study, information about Alfred Kinsey and his work in the Sex Institute in Indiana University that, I forget the actual title, but that's still around today, doing a lot of great research. It's a great video. It's about 12 minutes. It talks about the physiological aspects of sex as well as the psychological, and how it gets kind of messy when we study it, as you will see, because there's so much morality tied up in how we view sexual encounters, right? Yeah, so we're going to look at all of these different things, and we are going to, it's kind of hard to have a conversation of sex without the morality factor, but I think one thing that's really important we're going to talk about is consent, because consent is kind of the differentiating factor when we get to some of the fetishes and paraphilias, and you'll see what I mean. I'll emphasize that. But when we talk about sexual disorders, we're going to talk about sexual disorders first. These are disorders that are actually have to do with the physiological and sexual response cycle. Now, there are psychological components, but sometimes those psychological components can lead people to not being able to be aroused or not engage in intercourse. And so we're going to talk about the sexual response cycle, which I've put it in a diagram on this page. So Masters and Johnson, back in the 60s, did some research on the body's physiological response to sexual intercourse. So they measured like 700 sex workers and watched them have intercourse, and they had them hooked up with electrodes and all of these different things to measure like blood flow and all of these different things with the genital region, like seeing how it changes as a result of the physical act of sex. And so we see on this y-axis, we're looking at arousal, and on the x-axis, we're looking at the passage of time. So there is a bit of a difference between the male and female level of arousal in sexual intercourse, and it can vary based on, if a woman has an orgasm or not, like how they resolve the sexual response cycle if they don't have an orgasm during intercourse, or if they have multiple orgasms. Whereas men, you'll see the scale looks a little different, but Masters and Johnson divided it generally into 4 stages: desire, excitement, orgasm, and resolution. So desire is when things start building up, blood flow starts happening, the interest in sex is there. And excitement is all these physiological changes, people with penises having erections, people with biologically female genitalia, having some lubrication and swelling of the vaginal canal. And so then, once all these body processes and people initiating sex, they actually will climax or reach orgasm. Well, according to Masters and Johnson, right? Remember that. This is what they charted out. So once you reach orgasm, there's peak arousal as well as pleasure, and the body kind of rhythmically contracts in biological males to push the sperm through, and in females, biological females, to kind of contract the uterus to be accepting of that seminal fluid. And then you have a resolution where it kind of tapers off and the body kind of returns to normal and resets. For men, there's a refractory period, so it takes them longer to initiate this process again, whereas women are quicker to reinitiate the sexual response cycle according to Masters and Johnson. Now, this is all fine and good, but with this linear perspective, it doesn't always work so perfectly. So as you can see, there have been some changes over time. Because again, sometimes some people don't have an orgasm when they engage in sexual intercourse. Sometimes they have multiple orgasms. And there are psychological factors that can sometimes inhibit people in the act of sex. And so when we're looking at disorders of sexual desires, we are looking at disorders that affect one or more of the first three phases. So problems with desires, problems with excitement, problems with orgasm. Resolution just kind of happens, so we don't focus as much on. There's nothing really that happens there. That's just like the tapering off. And so with disorders of desire, you have people who have loss of sexual interest. They don't really have the sexual fantasies. They're not really responsive to sexual cues, and there may not be an arousal factor. There's no desire to engage in sex. And this may cause distress about the situation because maybe, they want to be intimate with their partner, but they can't because they just don't feel like it. Maybe their partner's asking them questions, and they're like, well, I don't know why I feel this way. I just don't want to. And so that can create some situations, and psychologically that can affect them as well. And there are a bunch of different causes of low sexual desire. They can be biological, right? Abnormal hormone levels, for example. We have psychological causes looking at anxiety, depression, anger. Even biological, people are taking antidepressants or other medications that can affect your sexual desire, your libido, right? And then sociocultural, there's different pressures on people to perform in sex, and sometimes if people have traumatic experiences with being molested or having been assaulted in the past, it can be hard for them to want to engage in sex, especially if they haven't moved through that trauma. There are disorders of excitement. So remember our little chart. Let me go back. So that excitement phase when the body starts like gearing up for that sexual encounter. Typically what we see is this change in the pelvic region, so the general physical arousal. It's problems with the blood flow, the heart rate, it's not coming together to work for the person. So we have female sexual arousal disorder, where maybe the vagina and the vaginal canal, it doesn't become lubricated enough to engage in the sex act. That's just one of many things that can happen. Whereas men can have male erectile disorder or impotence, so they may not be able to have an erection. So these are disorders of excitement, so kind of like physiological kind of necessities for engaging in those different acts. And then there are disorders with orgasm in and of itself. Some people may not be able to achieve orgasm, or for example, what occurs in biological males, premature ejaculation or delayed ejaculation. So ejaculating within a minute of having sex with a partner. That's one of the biggest criteria for qualifying for premature ejaculation. And then there is also delayed ejaculation, which can be absence of orgasm with sexual activity for a partner. And so when we talk about these issues, there are a whole slew of therapy and treatments that can help it, and we're going to address that. But there are psychological theories underlying the orgasm or these disturbances in orgasm, because it is a largely psychological component when people have an orgasm. There's a physiological component and a psychological component. So it could be performance anxiety and the spectator role. So there's different ways to move through that so that not so much of the stress is on the person to perform these sex acts, but kind of like sharing in the performance and the pleasure. I guess as a way to kind of share the responsibility to kind of diminish that anxiety. Different masturbation habits or tactics to stimulate the person. I'm going to say biological male, but to stimulate the biological male or the penis specifically. So if someone has problems with delayed ejaculation, teaching them more about their body and how to make, it's kind of like coming familiar with yourselves and your body. And the treatment can be kind of the same for women, but of course different because you're dealing with different functioning parts. But understanding what pleasures you and how that can translate to an intimate relationship. And then there's also hypoactive sexual desire disorder. So anytime you see hypo, it means less or lower. So that's just when someone has a low sexual desire to the point where it fits that criteria of being abnormal. Because sex is a normal part of the human experience. And actually, when we're speaking of female orgasms in particular, it's tough because there's a large amount or percentage of women who do not have orgasms or with vaginal penile intercourse. So maybe they have to use other methods to stimulate that region. But 10% or more, 21% of women to some degree, for at least 6 months, have displayed a significant delay in frequency or absence of an orgasm, or are unable to achieve past orgasmic intensity. So this is the inability to kind of sustain or fulfill that orgasmic state. And so this affects about 21% of women to some degree, which is a pretty high percentage when we're looking at the numbers of the other disorders. While for men, premature ejaculation 30% worldwide. That's an interesting statistic considering what's kind of perpetuated in the media. So it is abnormal functioning in that it's distressing for the person. They can't have a fulfilling sex life. But I guess the main message here is that these people are, if this is happening to you or someone you know, they're not alone. It's more prevalent than it's talked about, and that's because it is such a taboo issue. And so there's some psychological theories on why women may have these female orgasmic disorders. So there could be biological causes like underlying diseases, any drugs or medication. We find that some drugs or medication, there's a good array of them that can affect one's performance in the bedroom. So with that being said, we should always be mindful of the drugs and their effects on people. And I've heard antidepressants can significantly affect your sex drive. There's also psychological causes. So if you have anxiety or depression or childhood trauma, all of these things can affect, how you interact or how you encounter sexual encounters, right? Think about classical conditioning way back in Psych 150, right? Classical conditioning, we learn to associate different stimuli and events, and if you have something traumatic, it's such a powerful stimuli that we've learned to relate to that sexual encounter. So it may be hard to engage in it if the relationship is there. And then there's sociocultural causes as well. We think of religion and society in general, the kind of restrictive role of women. Women have been largely taught that, sex is for procreation and not so much for fun. We find that these notions are kind of changing, but this still can impact, how women enjoy sex. And then there are disorders of sexual pain, which cause, obviously by the title, physical pain upon intercourse. And usually this happens with women. And dysfunctions, generally these are they don't fit in the specific phases of the cycle, but it's abnormal and there's an enormous amount of physical discomfort during intercourse. And sex shouldn't be painful, okay? So that's one thing we need to remember. Sex should be pleasurable. If it's painful, it's important to communicate with your partner to make sure that, things are stopped, maybe trying something else. I guess that's my preachy side note, but just remember, sex should not be painful. So if you're having sex, pain during sex every time, there may be some kind of underlying issue there. And so sometimes it can be like fear, like a learned fear. We talk about CBT and classical conditioning. Could be infection, disease, menopause, because there's a lot of changes with the body where it's not maybe lubricating itself enough, so that could lead to some pain. And I don't know how to pronounce this. I'm freezing on here. I always mess it up. Dyspareunia. And this is what we're looking at with those physical causes of what's the issue behind why are we having pelvic pain during intercourse. And this is one of the things that could possibly be an explanation. And I think this is something that has to deal with the flexibility of the vagina in receiving the penis, but now I'm not sure. Now I have to look it up because my brain's... Don't quote me on that one. But treatment, I'm going to end this first part of the PowerPoint on treatment. So treatment for sexual dysfunction, sex therapy, we have a whole slew of different methods, which you're going to see on this slide, and I want you to review. But honestly, our textbook does a great job of laying it out. So I don't think, if you have any questions, of course, come to me. But I will talk about the psychological aspects. Not so much the physical maneuvers that are suggested, but just know that sex therapy has changed a lot since Masters and Johnson. Our text talks about how it's much more inclusive. Back in the day, they wouldn't treat LGBTQA individuals. They wouldn't treat unmarried individuals. They wouldn't treat people with disabilities. You know, they wouldn't, I think I said unmarried people. There's a whole slew of people that can have sexual disorders, whether they have an active partner or whether they're casually having many partners. You know, it should be addressed because that's, again, a natural part of being human is engaging in sexual activity. And so if there's an issue there, it should be helped, especially, you know, people who have largely been seen as, like, not having sexual intercourse, like people with disabilities. People with disabilities still have sex. And so it's important that everyone gets the treatment that they need. So sex therapy, it depends on what kind of therapy the person is going to engage in. But typically, it's going to be short-term and instructive, about like 25 sessions max. And it's going to focus on what the issue at hand is. So maybe not so much trying to find the deeper root to the issue. Like if someone's having an issue with orgasm that's rooted in some past trauma that they've had, then they would address that issue. But largely they'll say, oh, well, if you're having troubles, you know, fantasizing or wanting to have that, or having desire to engage in sex, then let's target that specific behavior. So they're very focused on one aspect, or whatever aspect is bothering the person. So they conceptualize that problem, and they give this notion of mutual responsibility. So if someone is going to sex therapy with a partner, and knowing that, you know, it's both of the partner's jobs to communicate those needs. It's not just on the one person, like, hey, figure your stuff out. No, it's a team effort. If you're going to engage in these acts, then they should be supportive of one another. Education about sexuality, there's a lot of misinformation out there. So it's important to kind of clear some of that misinformation and educate people, especially women who have orgasmic disorders, you know, who may not have engaged much in masturbation previously, maybe teaching them therapeutic techniques that involve masturbation. That may help them in becoming comfortable with their body and their processes and knowing what makes them feel pleasured. Changing attitudes, kind of address that with the talk about changing misconceptions and, you know, is sex for fun or is it pleasurable or for procreation? You know, what's the purpose? Maybe dispelling any shame that accompanies that. Elimination of performance anxiety, increasing sexual and general communication skills, because communication skills are important, and they're also important when engaging in sexual acts. Just like consent is important. It's important to talk with someone when something's uncomfortable, or if you don't like it. Don't continue doing things if you don't find them pleasurable or if you don't like them. Changing destructive lifestyles and marital interactions. So that's a little deeper, but looking at kind of lifestyle choices that may affect someone's sex life. So maybe if they're engaging in habitual drug use and it's affecting their sex life, there's probably a lot of therapy that needs to occur. But also if someone's not emotionally invested in their marriage and maybe that's affecting their desire to have sex, maybe going to couples therapy to figure out communicative alternatives and methods. And looking at those physical and medical factors, of course, if it's not something rooted in psychological functioning. This is all for part 1. Stay tuned for part 2 where we're going to talk about gender, or paraphilias, and gender issues, which are not related.